Dear audience, I am very pleased to present you the work of my last 12 months about my topic in the PhD. I am investigating the role of left atrial strain in neurocardiology. Briefly about myself, my name is Henriette Mészáros and I work at the Heart and Vascular Centre of Semmelweis University. My vision is that I can see in my everyday practice at the clinic that the detection of atrial fibrillation requires expensive prolonged monitoring. So that's why derives my mission that I would like to decrease the necessity of prolonged monitoring with the help of my study. I have two specific goals. In the first, I am investigating the baseline differences in left atrial strain deformation imaging parameters in patients developing atrial fibrillation in the future. I've started this project 1 year ago in last September. And as a second project, we are aiming to investigate the effect of high versus low mesh density device on atrial strain in patients with patent foramen ovale. Let me first speak about my first project. I have sent my manuscript to internal review, and we also made a prestigious journal selection. And we would like to submit our journal in the first in our first choose. This is the JACC cardiovascular imaging, and we hope for the best. So about the background of my first study. As we all know, old age comes with comorbidities, and in cardiology it can result in left atrial remodeling, the so-called atrial cardiomyopathy, which forms ground for atrial fibrillation. And we all know that atrial fibrillation makes a prothrombotic stage in the left atrial appendage, and it can result in thrombus formation and cardioembolic stroke. Nowadays, the gold standard method of diagnosing atrial fibrillation is only prolonged ECG monitoring, but it is very expensive and there is no consensus on the appropriate modality and duration among the most prestigious cardiologists as well. So that is why it derives our idea that we should implement in the everyday practice very useful tool which could assess the left atrial remodeling non-invasive. This is the left atrial strain analysis which predicts the occurrence of atrial fibrillation, and our aim is to limit the range of patients who need prolonged ECG monitoring. So we put the clinical question: is the decreased left atrial strain associated with the occurrence of atrial fibrillation? Here you can see my PICO framework. So basically we compare two groups of patients, who had a left atrial strain analysis, but there was one group who was detected with atrial fibrillation during follow-up, and there was the other group without detected atrial fibrillation during follow-up. And our main outcomes were global longitudinal atrial strain and contraction strain rate. And our hypothesis was that patients with atrial fibrillation have decreased atrial strain. Here you can see the flowchart of our selection, and at the end we had 6 eligible full texts. So let me speak about the results of my first research topic. So in the right upper, so in the right lower small picture, you can see this strain analysis software, how it works. It contours the left atrial endocardium and makes the measurement. And you can see, as I already mentioned, I had 6 eligible full texts, and we were, because of the low number of studies, we were working with high heterogeneity, and but at the end we had also statistically and also clinically significant difference in those who developed atrial fibrillation during follow-up compared to those who did not develop atrial fibrillation regarding this global longitudinal atrial strain, which represents the strain curve of all, so the whole left atrial cycle. Our second main outcome was left atrial contraction strain rate. It is the most specific strain parameter regarding atrial fibrillation development. Here we had 3 eligible articles for analysis, and at the end we got also statistically and clinically significant difference between the 2 groups. So we could conclude that those patients who developed atrial fibrillation during follow-up had significantly decreased left atrial contraction strain rate at the baseline screening while they were in sinus rhythm. So let me highlight the strengths and limitations of my work. So the undubtable strengths is the novelty of the topic. This is the first meta-analysis in this topic, but a few limitations are that there was no uniform data reporting regarding different monitoring methods used for atrial fibrillation detection, and the age heterogeneity was also present, which is known that strain values are decreasing by age. So let me summarize my findings. We found that this is an implication for practice that we could select patients who need prolonged heart rhythm monitoring and those who need anticoagulation immediately. But there is a huge implication for future research because our results are not strong enough to predict cutoff values of this strain. Here you can see my conclusion. So let me speak briefly about my second research topic, which is a protocol of a single center randomized trial. And about half of all cryptogenic strokes are related to patent foramen ovale. And the PFO closure is a very effective secondary prevention compared to antiplatelet therapy only. But in the first 2 months after the closure, the incidence of atrial fibrillation increases. So we saw that both electrophysiological and mechanical changes can occur in the atria, and there is no recommendation regarding PFO device type. So here you can, while you are watching this short animation, I would like to tell you that we would like to compare 2 different mesh density types of this PFO closure device regarding left atrial deformation parameters, these left atrial strain values, which I just highlighted in my meta-analysis. So here you can see the procedure that the hole between the 2 atria is closed, so the risk of recurrent paradox embolization can be reduced. Our clinical question was what I already mentioned, and we would like to deal with patients over 18 years, and we would like to compare patients who had the PFO closure with high mesh density device and patients with PFO closure with low mesh density device. The primary outcomes are change in left atrial strain parameters, and secondary outcome developing atrial fibrillation. And we have a huge clinical and research implication. We would like to decrease postoperative atrial fibrillation. Here you can see our protocol drafting, and we also plan to have a control group, patients who were referred to our neurocardiology lab but were not eligible for PFO closure because of several factors. Yeah, and as I mentioned, the main outcomes are a change in left atrial strain parameters, and secondary outcomes are, of course, atrial fibrillation and recurrent stroke. And here you can see the progress of my second project. We already finished the protocol drafting and the sample size calculation, but in our neurocardiology working group, we are waiting for the common approval and sending it. Thank you for your attention, and here you can see my favorite quote, one of my favorite quotes.
Thank you. I have a very ugly question to you, and sorry for that. You will compare the high and low density mesh device in the PFO closure randomized study, or study. Isn't it possible that more resizing of the PFO device is responsible for atrial fibrillation development? More sizing issue than mesh issue?
Thank you for your question. Yes, it is a very great question also for us, but there are complicated PFO anatomies. So these so-called complicated PFOs, which can be very floppy aneurysmatic PFOs. So in that special case, we have to implant a bigger device to decrease the risk of maybe device embolism or something. So that's why it is our vision that we should either talk about the mesh density than the size, because there are some cases in which we have to implement a bigger size device, but so it is necessary because of the complications. So that's why we thought that maybe we could handle this issue by lower mesh density devices.
Thanks.
Concerning the first project of yours, I would like to ask what was the method in the serial of manuscripts for investigating whether the patient is in sinus rhythm or atrial fibrillation during the follow-ups, because you have mentioned in the limitations that there were different methods, but how could they differentiate, how could they rule out the paroxysmal atrial fibrillation in this patient population who is considered to be in sinus rhythm? Because this is a very important issue, because all these patients should be, even based on the Chadwell score, anticoagulated as well. And sometimes if they have only serials of ECG at the GP's office, they would show a sinus rhythm, but maybe in the night, during the night or between the two show-ups, they could have atrial fibrillation paroxysmally. What were the methods in these manuscripts?
Yes, it is a big limitation, as I already mentioned, so that's why we are needing a big randomized trials on this issue. But there were differing methods like 72 hours of Holter monitoring, 24 hours of Holter monitoring, only symptoms-driven Holter monitoring, only so-called in-office hookup when they were back to these controls. So these were mainly, and I think there was one study with loop recorders, but of course you cannot implant this in each patient, so it is a quite complicated issue to overcome in the future studies.
It would be worth to consider some kind of explanation for that for the last version of the manuscript, because this will be the first question of the reviewers. How can you state that the patient was in sinus rhythm? Not you, but the other authors.
Yeah. Thank you.
Thank you.
And Henny, as you said, in this case, the age is a very severe confounding factor, because with the aging, the strain rates and all the parameters which are related to this actually decrease. So could you somehow balance it and avoid the possible influence of this confounding factor?
So you mean in this meta-analysis, so overcome the age heterogeneity? How should we overcome age heterogeneity? Or?
Yeah,
okay.
How did you handle the aging? I mean, could you perform, for example, any subgroup based on the age of the population?
Unfortunately not, because we had a few studies, so there were not enough studies regarding this topic, so that's why we could not make this subgroup analysis, but it would be very helpful, and it would be very great, and it would even make a better meta-analysis, but at that point we did not have eligible studies regarding this issue, and I also searched after my first search in the literature, but there are not so many studies yet regarding this topic. So unfortunately we did not do it.